So now coming into CK, we're going to be learning a lot more about pregnancy in terms of how you're going to be managing that in a hospital. Um, OBGYN was definitely one of my favorite rotations I did because that was an amazing experience to help give birth, right? So that was one like I witnessed my the physician I was working with. I witnessed them do it. I believe, if I recall correctly, 5 different deliveries, and it was so weird that rotation because of the timing. So I was practically on call like all the time. The physician would just call me at like 4 a.m. be like, "Hey, be here by 5, whatever. Someone's gonna deliver it. Need you to see it, something like that." And I would just show up. And then one day I showed up and she was like, it was a female doctor, so she was like, "You're gonna do the delivery today," and it was pretty epic. It was very scary. I was worried, of course. The common worry was that I would drop it or something, but it was pretty good. I pulled it out just fine. No shoulder dislocations or anything like that. Super slippery, and then the nurses take it from right there. So a really interesting field to be in. So the first thing that we're going to see here is the physiology of normal pregnancy. Now, physiological things that occur in normal pregnancy, if the same things occurred in another woman that is not pregnant, then it's no longer physiological, right? So that's something to keep in mind because they will always be showing you things that look pretty pathological, but then you realize that the woman is pregnant and all of a sudden it's not a pathology anymore, then it's normal for her to have those things. So on the left, we could see some things right here. So we have the hematologic changes of pregnancy and the cardiopulmonary adaptations to pregnancy. So these are basically going to be things that are going to be critical in cardiovascular questions regarding pregnant women. So you can see plasma volume significantly increases, red blood cell mass, which is basically polycythemia, right, increases, hemoglobin concentration decreases, and platelet count decreases. So now, hemoglobin concentration decreasing doesn't mean that hemoglobin decreases. The amount of hemoglobin is still there, but the concentration is relative to what else is around, right? So the hemoglobin gets diluted by the excess plasma. So that's what that means. Always keep in mind when you're reading questions, reading any explanation, if they're saying some kind of concentration changed, that doesn't mean that the amount of the thing changed. It's like it's being diluted out or something like that. And we're going to see questions when we look at practice questions where this is going to play a role. As far as cardiovascular adaptations, you can see cardiac output has to increase. Plasma volume here is also elevated. And systemic vascular resistance is going to decrease. You're going to be sending out more blood, but not necessarily to yourself. It's more blood being sent out due to the placenta. That's what's happening there. Always remember, vascular resistance shouldn't be high in a pregnant woman because then if she ends up getting hypertension, that's grounds for preeclampsia, which is definitely a big problem, right? Respiratory changes, you're going to have an increased tidal volume, but a decreased functional residual capacity. The FRC, so now if you haven't really looked at the respiratory volumes in a long time, you might want to go back and check that out. But the FRC is directly related to how much space you actually have. Like residual capacity or residual volume was all air that was left in the lung after you were done breathing out. So they breathe out even more air because there's an elevation of the diaphragm. Remember that the way you breathe, when your diaphragm goes up, something happens, and when your diaphragm goes down, a different thing happens. In us, when the diaphragm goes down, that's when we're breathing in. And then when it goes up, you're breathing out. If it goes up too much, you breathe out more of the residual volume, right? And in them, it is going up more and more, especially later on in like the second and third trimester because of the gravid size of the uterus, right? The big baby. Clinical manifestations are going to be peripheral edema, decreased blood pressure, increased heart rate, a systolic ejection murmur that is physiological, and dyspnea, right? Which are all basically showing you that the mother is starting to have a little trouble with the baby, and pregnancy isn't easy. So of course she's having a little trouble. None of this is to show you that she has heart failure or anything. Do not pick that. All right. I can confidently tell you that 100% of questions I've done of a woman who is pregnant, the answer was never heart failure. It's never heart failure. In fact, the only thing that can occur in pregnant women that is actually taught in step 1 as well is dilated cardiomyopathy. But the dilated cardiomyopathy of pregnancy, or even like after delivery, isn't exactly very pathological, all right? And it recovers by itself. It fixes itself soon after delivery. So dilated cardiomyopathy is one of the things, when you learn, let me find it here. When you learn about the ABCCCDs of things that cause dilated cardiomyopathy, there's a bunch of other things after the D as well. And you need to know them as well, like hemochromatosis and sarcoidosis and whatnot. So you can see here, the hemochromatosis, sarcoidosis, thyrotoxicosis, and then right here, peripartum cardiomyopathy, which is what we're talking about right now. Right. So this was actually this is a pretty commonly asked question that I kept finding in NBMEs for step 1. So they enjoyed this because it was really something that would confuse people when it came to questions about pregnant women. All right, so that's what that was about. Okay, so here they start talking the basics of pregnancy. The terms and concepts that follow are central to an understanding of the physiologic process of pregnancy. Gravid. So I just said a little while ago, a gravid uterus. So gravidity is the number of times a woman has been pregnant, right? How many times has she had that gravid uterus? Parity is the number of pregnancies that led to a birth beyond 20 weeks gestation or an infant weighing more than 500 grams. So this is a good number to keep in mind. 500 grams is, if a baby is born less than 500 grams, that's pretty bad. That baby's probably not going to make it. In prenatal assessment, TPAL expresses the number of term deliveries, the number of preterm deliveries, the number of abortuses, and the number of living children. Right, so oftentimes you will see for a woman coming in that's pregnant, it might say T and then a number like T1, P1, A0, L1, something like that, right? So she's had term deliveries. She's actually, it would really say T1, right? T1, P0, A0, L1. That would mean she's had one term delivery and that baby is living. It's a living child. 0 preterm deliveries and 0 abortions. So those are some things that you see. And when I did my rotation, that's where I first learned about it. We usually don't really talk about TPAL that much in actual clinical practice. In actual clinical practice, it's just P and G. So you might write like P1, G1, right? Or G1, P1, GP. G1, P1, meaning she's been pregnant one time and she's delivered one time. That's it. Right? But that's like something that depends on where you're rotating and stuff. But you do need to know this. Now, thankfully, in step questions, they don't really use these notations that much. They'll actually use the full words. Developmental age versus gestational age. Very confusing little topic, but developmental age is the number of weeks and days since fertilization, right? So if your birthday is like, let me see, let's go with September. So if your birthday is September 1st, or actually let's say October 1st, right? So let's say your birthday is October 1st. From your October 1st birthday, whatever you're figuring out, that's usually your gestational age. Developmental age is when you were developing from the first 2 cells that combined and made a zygote. So you would have to go back 10 months. So that means developmental age would be about January, from January, something like that. But developmental age and gestational age are not that far apart. It's just how long pregnancy and delivery takes. All right. Gestational age is the number of weeks and days measured from the first day of the last menstrual period. So if they tell you in the question that the woman had her last menstrual period, the first day of her last menstrual period was like October 1st, you can measure from there, or you measure from there to get gestational age. So gestational age and developmental age are pretty much going to be about the same, right? There shouldn't be a significant difference between the two. Gestational age can also be determined by the following things. Now, this is often going to be given to you in questions. The fundal height. And oftentimes you'll read that in the question and you won't have any idea what it's supposed to mean. In fact, that's what happened in step 1. In step 1, when we were told the fundal height, we didn't really know what it implied. What do I do with that information? So it turns out that if you take the fundal height is umbilicus minus 20 weeks plus 1 centimeter per week thereafter. This is the fundal height. And you can use that to figure out if the development is going accordingly. There's a chart that you can find. Let me see. Fundal height chart. That kind of gives you the idea of how much of the fundal height should be by a certain time. So like this right here. See, so you see the number of weeks, so you measure the fundal height up to the umbilicus, and you can measure further up as well as the woman gets more pregnant. Right, it's measured in centimeters from the pubic symphysis to the topmost portion of the uterus, which would go all the way up. But most physicians know that you can just double it from here or something like that. All kinds of ways to do it. But from the pubic symphysis all the way to the top right there, which would be at the bottom of your mediastinum, the xiphoid process. And whatever that distance is going to get more and more as the pregnancy proceeds and the belly comes out more, right? So that helps you understand if pregnancy is going accordingly. And depending on what number you got, 12, 16, 22 weeks can be figured out, right? So that's one way to evaluate. If sometimes people don't know how long they've been pregnant for, that's one way to evaluate it. Fetal heart tones are going to be a big part of the test now. You're going to be given actual fetal heart tone graphs, which you're going to have to evaluate. Typically 10 to 12 weeks. Quickening or appreciation of fetal movements occurs at 17 to 18 weeks. And ultrasonography measures the fetal crown to rump length at 6 to 12 weeks, the biparietal diameter, femur length, and abdominal circumference from 13 weeks. And ultrasound measurement of gestational age is the most reliable during the first trimester. This is usually an answer you'll have to pick. Right? If you try to figure out the gestational age, what do you measure? And then you're going to have fundal height as an answer choice, first day from the last menstrual period as an answer choice, a couple other answer choices, and then ultrasound. Right? So if it's still the first trimester, the ultrasound is the most reliable measurement of gestational age because you can literally look at the baby and figure out these measurements and know what the gestational age must be. Right? We usually care about gestational age, not so much about developmental age. I'm not really sure why we even talk about it so much because it is usually unknown. Right? No one really knows the day they got fertilized. Like, that's a really weird little thing. So here they give you notation, right? So a G3P1 woman is one who has had 3 pregnancies, but only 1 birth beyond 20 weeks gestation, and or an infant who weighs at least 500 grams, right? More than 500 grams. So G3P1, G4P2, stuff like that. These are the mnemonics not mnemonics, but the notations you use in actual clinical practice. Key fact, get a quantitative serum beta ACG to diagnose ectopic pregnancy, to monitor trophoblastic disease, or to screen for fetal aneuploidy. Pretty much every time anyone comes in with a missed period, you order a beta ACG. Right? Even if they tell you they are sexually inactive, you order a beta ACG. So here we have diagnosis of pregnancy. Beta ACG, the standard for diagnosing pregnancy, can be detected in serum or urine. Serum ACG is more sensitive and preferred if the menstrual period is less than 1 week late. Produced by the placenta, peaks at 100,000 units per milliliter by 10 weeks gestation, decreases throughout the second trimester, and levels off in the third trimester. ACG levels double approximately every 48 hours during early pregnancy. This is often used to diagnose ectopic pregnancy when doubling is abnormal. And this is going to be a key feature of figuring out if someone has ectopic pregnancy if the question is trying to be a hard question and they're not trying to make it very obvious. So they might give you like a table of how much ACG was at different time intervals, right, throughout maybe the first week. And if it's not doubling in that first week of pregnancy, if it's not doubling every 2 days, right, maybe it's increasing or staying the same but increasing very slowly in the first week, then that's not a normal pregnancy. Right? It's not a normal pregnancy. Then you have to figure out what kind of pregnancy it might be, and you do the evaluation to see. Ultrasonography is used to confirm an intrauterine pregnancy. Gestational sac is visible on the transvaginal ultrasonography by 5 weeks gestation, and a beta ACG in the range of 1,000 to 1,500. Right? So there's a bunch of ways to figure out what's happening with any kind of pregnancy. And most of the answer choices are going to be to just do an ultrasonography. Keep in mind, we're going to see soon enough that there are many kinds of radiographic tests you cannot do cannot do on a pregnant woman or even a newborn, because it would destroy the developing baby's fresh cartilage or brand new DNA and all this, and it's very, very harmful for babies. But ultrasounds are not harmful for babies at all. Minimum harm, if anything. So you can always do the ultrasound. Now take a look at this question. Very interesting question. Always love these questions on UWorld because they teach you something really good when the answer is just reassurance. Right? You don't do anything. So what's happening? 24-year-old woman, G2P1. So that means she's been pregnant twice. She's delivered one baby successfully after 20 weeks. So right now she's also pregnant. That's the second pregnancy, right? At 37 weeks gestation, comes to the office requesting induction of labor. She says that the last few weeks of pregnancy have been very uncomfortable due to exhaustion and shortness of breath when walking. Well, she's 37 weeks pregnant, so she's definitely going to be very uncomfortable. She has bilateral leg swelling and is unable to fit into her shoes. She has difficulty sleeping at night due to bilateral crampy pain in her calves that is relieved by massage and stretching, and because the baby moves frequently at night. Yes, it's going to be very difficult to sleep. So her problems so far have been difficulty sleeping, edema in the legs, and shortness of breath. Right, shortness of breath. So these are all pretty typical things that you expect in any pregnant woman who's 37 weeks pregnant. Right, this is like, by this point, she's been doing this for 37 weeks, and on top of that, the baby is huge. Going on, they tell you review systems is negative for any contractions, vaginal bleeding, and loss of fluid. We're going to learn what contractions really mean for us as physicians as we go on. But presence of contractions is a huge sign that the baby's ready to deliver, right? And depending on what time of the week it's happening. If it's happening too early, then the baby's ready to deliver too early, which is problematic. Urinalysis shows trace protein. Physical exam shows symmetrical bilateral pitting edema of the calves, ankle, and feet. Cardiac auscultation shows a 2 out of 6, so not a loud one. Systolic ejection murmur. Her lungs are clear to auscultation. What's the most appropriate next step in her management? You tell her it's going to be okay. You make her feel a little better. Tell her all these symptoms are normal to occur at this level of pregnancy, and keep doing routine follow-up as you should be doing for someone who's pregnant, right? And that all these changes came from this table, right? All these things: peripheral edema, systolic ejection murmur, dyspnea, right? Difficulty breathing correctly. She has elevated plasma volume causing those edema. It's all normal stuff. Pregnancy causes maternal hemodynamic changes that include an increase in cardiac output and plasma volume, as well as a decrease in systemic vascular resistance and blood pressure. The increased cardiac output results from an increase in stroke volume in early pregnancy and a faster heart rate in late pregnancy, and is frequently accompanied by a systolic ejection murmur because there's a lot of blood. Dyspnea is also common due to respiratory adaptations to pregnancy, with your diaphragm coming up. Progesterone induces increased minute ventilation through an increase in tidal volume, but the respiratory rate is unchanged. The enlarging uterus causes the diaphragm to be elevated, resulting in decreased functional residual capacity because you breathe out more air than you normally would. Nocturnal leg pain is also common due to muscle cramping from lactate and pyruvate accumulation. Reassurance and routine prenatal care are indicated for this patient who is experiencing normal manifestations of physiologic pregnancy. So now we're going to see a whole list of normal physiology of pregnancy, a bunch of stuff that occurs that questions are going to constantly try to throw at you as if they're pathological. Sometimes it might be very convincing that it is pathological, but then you'll remember that they're pregnant and you'll understand it's not. Unless something extremely red flag is occurring, then you start thinking this is a pathology. The normal physiologic changes that occur are during pregnancy are graphically illustrated below. Low back pain is common in the third trimester and is caused by increased pressure from the uterus and laxity of the muscles and joints. Very obvious thing. Maternal failure to gain appropriate weight is associated with intrauterine growth restriction, while excess weight gain is associated with diabetes. Right? You get a bigger baby with diabetes. Pregnancy causes a hypercoagulable state. So now here, we're going to keep seeing a bunch of stuff on this next page too. Here they show you renal stuff. So renal and uterine body weight changes in normal pregnancy. So you can see how renal flow, as the number of weeks is going from 0 to 36, renal flow is increasing in the beginning. then it stays stable, and then it starts going back to normal. Right? This is your renal flow. So this is also related to the fact that the baby doesn't really have much of a functional kidney in the beginning, right? And then the baby's kidney is starting to develop, and then once the baby's kidney is functional, you bring the renal flow back down. Right? The percent change goes back to normal. Remember, this is showing percent change. So how much change was there? There was a lot. The change stayed steady, no more increase in change, and then change went back to normal. Right? GFR increases. Halfway up to pregnancy, GFR goes up quite a bit, and then it stays there until the end of pregnancy. Right? So glomerular filtration rate. They tell you here that renal flow increases 25 to 50%, GFR increases early, then plateaus. Uterine weight increases from 60 to 70 grams to about almost 1,200 grams, and body weight should increase about 25 pounds in the woman. Right? That's what happens, not because the baby is 25 pounds, but because she's increased in plasma, she's increased in many other things in herself, plus the size of the baby. So this is pretty commonly seen. Right? So now, to be entirely honest, I haven't really seen many renal questions for this topic, because I guess there isn't really much to ask about. Because it's very easy to remember that GFR and renal flow will both increase. They have to increase. There's more blood circulating, and the baby doesn't have a functional kidney. By the time the baby does have a functional kidney, renal flow starts to slow down and go back to normal again, but GFR stays high until the baby is delivered. All right. They go on to show a couple more things, so we'll come back to prenatal care later. Here we have the cardiovascular graph. So this is the most commonly tested for pregnant women. The most questions on step 1 and step 2 both. So you can see, of course, cardiac output increases, heart rate increases, and blood pressure decreases. We know this, right? This is something that we've been looking at for a very long time. You should never pick an answer choice that goes in any other way whatsoever. Cardiac output rises rapidly by 20%, then gradually increases an additional 10% by 26 weeks. Heart rate gradually increases 20%, and blood pressure gradually decreases, then comes back to normal as the pregnancy is coming to term. Okay, these things are not going to be too hard to remember. You're not going to need to know the percentages per se, just a general understanding that these are the common things that occur. Right? Blood pressure has to decrease because there's excess pressure to begin with. So the lower blood pressure is the normal blood pressure of a pregnant woman. Right? If blood pressure goes up, then you know that's a really bad problem. Stroke volume increases to maximum at 19 weeks, then plateaus. Peripheral venous distortion, progressive increase to term. Peripheral vascular resistance, progressive decrease to term. Right? So venous distortion is going to keep increasing, but blood pressure or vascular resistance is going to keep decreasing. Right? These are some things that you can get as answer choices, really, just annoying answer choices, but not the most complicated thing. So this venous distortion thing is really just because of the various interconnections occurring with the placenta. That's all that's happening there. GIT is the easiest thing, so there's almost never a question on this either. All you're increasing here is gastric emptying time. Right? So the sphincter tone decreases. All that's happening is it's taking longer for food to pass through the stomach and go through the colon, because all of that area is now being kind of altered by the baby. So in the beginning, the change is very insignificant. But once the baby's size becomes bigger, gastric emptying gets significantly slower. Right? So that's why, although pregnant women will often be hungry, they can't really eat much, right? And as far as food is concerned, one major misconception is the cultural concept of eat more because you're eating for two. And that's not true. A pregnant woman isn't really two people. That baby is still a part of her, and all of her interconnections and everything are connected with the baby. We never really eat food considering, oh, I should eat more because I'm eating for my heart, my stomach, my legs, my arms. You know, the baby is just another part just like that. So we don't think like that when we eat, and we shouldn't think like that when we're eating during pregnancy either. That's just going to lead to excessive weight gain for the mother, and it's going to be very hard to lose that weight after delivery. Right? So just eat as much as you need to eat, but there's no concept of eating more because you're eating for two. That's kind of sort of a cute thing people like to say, but not a real factual statement. Circulatory system, of course, that goes hand in hand with cardiovascular. So this is also going to be often tested. We just saw that in pregnancy, one of the major things is that pregnant women are very hypercoagulable, right? So getting things like excuse me, getting things like a pulmonary embolism or a DVT is going to be very common in pregnant women. There's excess blood volume, so that's the polycythemia, normal polycythemia, right? Increases by 50% in the second trimester. Fibrinogen increases, which is adding towards the hypercoagulability. No changes to electrolytes. Now, I'm not sure why they're really spending time talking about this. Why would electrolytes change anyway? Like, electrolytes are not something you make or control. It's more from your intake. So, yeah, nothing happens to electrolytes. But I guess the significance here would be that if electrolytes do decrease, then that's a pathological thing to keep in mind. Where electrolytes could decrease, if you have renal failure or something's wrong with your liver, then you could lose electrolytes. And I guess in that aspect, sure. But we don't really look for electrolytes when we're trying to figure out renal failure. Other places where electrolytes can change are like having hyperaldosteronism or adrenal insufficiency. Right, those guys can alter sodium levels, and yeah, that could be something you would catch. But again, all of those are concepts or conditions we catch in other ways, not by looking at electrolytes. And then the hematocrit decreases, right? So hematocrit only slightly, not too much, by about 10%, and it's decreasing very slowly, very slowly. And because your blood volume is so high, you don't need to make more blood, right? And blood volume is mostly high because of plasma, not that you made more hemoglobin. Right, so those are also key things to keep in mind. One of the main things we increased a lot was your plasma volume. Plasma volume increased a lot, right? So that's happening there. Pulmonary system, as we saw a little bit earlier, your expiratory reserve is going to decrease a lot as the baby gets bigger. Your reserve volume is going to decrease because the baby is pushing the diaphragm up. That means more air is being pushed out, right? Respiratory rate and vital capacity stay the same, and tidal volume plus respiratory minute volume, as we just saw, the minute volume was altered by progesterone, right? So tidal volume and respiratory minute volume are going to be altered, right? They're going to increase, and that's, again, not stuff I've really seen being tested much. The most questions in UWorld for pregnancy-related physiologic changes were for cardiovascular, so we're going to see those as we go on. Actually, we can basically start seeing all of those right now. And then we're going to come back. So let's do all these practice questions. These are wonderful questions of things that are normal in pregnancy. So we're going to see all that. And then we'll come back to prenatal care, which is just taking folate, really. So first one here, cardiovascular contraindications for pregnancy. So 34-year-old woman, G1P0, which means that she's been pregnant once, hasn't delivered anything, so we're probably talking about her current pregnancy, comes to the office at 38 weeks gestation, so we always underline that, due to increasing shortness of breath. Excuse me. She says that the pregnancy is causing too much discomfort at the stage and requests delivery. Just like the previous question, this is pretty normal stuff. She can't find a comfy position to sleep in, and after walking several steps, she needs to stop to catch her breath. So breath and sleep, normal changes in pregnancy. Her pregnancy has been uncomplicated and she has no significant medical problems. Wonderful. She doesn't smoke or drink. Blood pressure is slightly high, and pulse is 102 and regular. S3 is heard on cardiac auscultation, which, remember, S3 was a sign of heart failure in normal people. There is a new grade 2 out of 4 holosystolic murmur at the apex. Now, a systolic murmur was somewhat understandable. That was normal. A systolic murmur was what we expected, a 2 out of 6 systolic murmur because of the excess blood volume. Well, a holosystolic murmur is usually a sign of the regurgitations, right? So either mitral regurgitation or tricuspid regurgitation. Pitting edema, that's normal too. So right now the most significant thing is the holosystolic murmur. Pitting edema is present over lower extremities. Urinalysis shows trace protein. ECG shows signs tachycardia. What is the best next step in her management? Now, people were very confused with this question, right? But when I was working with a student, I also made a mistake. So the correct answer was just to do an echo, 25%, while 20% chose immediate delivery, and 35% chose the answer choice you're always going to be confused about, reassurance and routine care. But there's a critical difference between this question and the one we did right here, where the answer was reassurance and routine care. There was literally nothing in her that we did not expect, but she had the correct 2 out of 6 systolic ejection murmur, but not a holosystolic murmur, right, which is only the sign of mitral or tricuspid regurgitation. Those are the ones that have a holosystolic murmur. They're regurgitating the entire time systole is occurring. That's why it's a holosystolic murmur. I also chose immediate delivery, but it makes sense to confirm the diagnosis to determine the plan. Peripartum cardiomyopathy is an uncommon cause of dilated cardiomyopathy that develops during the last month of pregnancy or within 5 months following delivery, as we spoke about earlier, dilated cardiomyopathy in pregnancy. Her clinical presentation with progressive dyspnea on exertion, lower extremity edema, and an S3 is suggestive of decompensated heart failure due to peripartum cardiomyopathy, which is often associated with mitral regurgitation. The diagnosis can be hard to make in late pregnancy, as symptoms and signs are similar to the changes in normal pregnancy. A transthoracic echo showing a dilated left ventricle cavity with global systolic dysfunction and a low ejection fraction below 45% can confirm the diagnosis. Urgent or immediate delivery should only be considered for patients with advanced heart failure or hemodynamic instability. So when I was reading the question personally, I recognized that this was mitral regurgitation. However, just hearing an S3 and holosystolic murmur is not what you need to diagnose mitral regurgitation. You need to do the echo, which is a pretty quick thing to do, a very cheap thing to do. You just order a quick echo, check it out, you would see the mitral regurgitation, that would confirm it. And then if it's really bad and looking like something that might be concerning, then you can go ahead and consider immediate delivery. Because it's not too late, like it's not too early for immediate delivery either. The baby is pretty much ready to be delivered. Right? 38 weeks is a great time to be delivered. So cardiovascular contraindications to pregnancy are symptomatic mitral stenosis, symptomatic aortic stenosis, symptomatic heart failure with a very low ejection fraction, under 30%, pulmonary arterial hypertension, huge emergency, and bicuspid AV with ascending aorta enlargement, which would be a Turner syndrome patient. Right? Keep in mind that Turner syndrome patients can get pregnant. They just have streak ovaries, right? They have streak ovaries, but they do have a uterus. They can get pregnant. You just have to implant it. Clinical features of peripartum cardiomyopathy is onset of heart failure during the last month of pregnancy or within the 5 months after delivery. You get a systolic dysfunction with lower ejection fraction under 45%, absence of other causes of heart failure, and absence of heart disease before getting pregnant. Right, so this patient has heart failure. The S3 and the holosystolic murmur were significant here, and you needed to do an echo, which was a cardiovascular thing. When we did cardiovascular, all the valvular dysfunctions were evaluated with echo. And the stenosis ones are more problematic than the regurgitation ones, because the stenosis ones will immediately raise blood pressure, right? If you have aortic or mitral stenosis, you're going to start getting an elevation of blood pressure. Your left atrium is going to enlarge if you have mitral stenosis, and your left ventricle is going to get hypertrophied if you have aortic stenosis, because those chambers are going to have to work significantly harder to open the valves that normally open pretty naturally. All right, so great question. Great question, especially in comparison to the one right before this, which was just reassurance and routine care. All right, so now we're going to be seeing questions where we're going to see things that happen to pregnant women that you may not have known about is a normal thing. 32-year-old woman, G2P1, at 28 weeks gestation, comes to the office for a routine prenatal visit. 3 weeks ago, she developed a facial rash that has darkened despite the use of lotions. For the past week, she has been unable to work at her job at a landscape company due to increasing fatigue and dizziness on standing, which are normal things that would occur to a woman that's this pregnant. She has had no contractions, vaginal bleeding, or leakage of fluid, which are all red flag symptoms that haven't occurred. So no red flag symptoms. Fetal movement is normal. She has no chronic medical conditions and takes a daily prenatal vitamin and iron supplement. Wonderful. Temperature, blood pressure, pulse are good. You want your blood pressure to be a little lower, as we already saw. This is the normal for a pregnant woman. The fetal heart rate is 145. Excellent. Fetal heart rate is significantly higher than normal, than the adult. Light brown, irregularly shaped macules are arranged in a bilaterally symmetric fashion on her cheek and nasal bridge. They're saying this in a very interesting way to make you think of lupus. The macules do not affect the nasolabial fold. Labs show a pretty normal lab. Everything is normal here. Urinalysis has a little bit of nothing, negative for everything. So everything is literally normal. There's absolutely nothing wrong with her. Right? We didn't see a single symptom that was really concerning or red flag. So these light brown macules, what are they? Well, they ask you what's the next best step, and the answer was no further evaluation indicated. What she has is melasma. Right? It looks like this. This is a picture showing you the light brown stuff right here in this area. Right? That's all melasma. An acquired hyperpigmentation disorder that occurs primarily on sun-exposed areas of the face. Melasma likely occurs when ultraviolet radiation triggers melanocyte proliferation and pigment deposition in sun-exposed areas. It's more common in women of reproductive age, particularly during pregnancy, as estrogen and progesterone also stimulate melanocyte proliferation. Additional risk factors include darker skin color, thyroid dysfunction, any anti-epileptics, or cosmetic product use. Patients typically develop irregularly shaped, hyperpigmented macules of varying color that look exactly like this, and there's nothing to be worried about. Right? Typically resolves postpartum, and areas that do not resolve can be treated with skin lightening agents like topical retinoids, which is what we use to get rid of the dark spots after acne. Right? So tretinoin, isotretinoin, stuff like that. You cannot use tretinoin or isotretinoin during pregnancy. Keep that in mind. You could use topical tretinoin during pregnancy, but isotretinoin is a pill that is very teratogenic. Right? These are all vitamin A derivatives, and it's teratogenic for the baby. So whenever you do ever prescribe any of these isotretinoin pills to women, you have to make sure that they're also taking oral contraceptives, and you have to do a negative pregnancy test as well. Another question here, where the correct answer was reassurance and conservative management. What happened here? 36-year-old woman, G2P1, 32 weeks gestation, comes to the office with dull low back pain radiating bilaterally to the buttocks and posterior thighs. The pain is minimal in the morning but increases with activity and at the end of the day. She also has ankle edema, numbness in her feet at the end of the day. She has urinary frequency, and nocturia, but no hematuria or dysuria. She did not have back pain in her first pregnancy. During that pregnancy, she received epidural anesthesia during labor and had a post-lumbar puncture headache after removal that was treated with an epidural blood patch. Excessive information that we don't really need to use for this question at all, but they're telling it to you. Vitals are fine. She has gained 44 pounds during this pregnancy, so it looks like it might be a heavy, big baby. Or she herself may not have maintained herself very well during this pregnancy and gained extra weight. On physical exam, she ambulates with a wide, waddling gait. Walking forward or backward causes no change in the pain level. There is no spinal or paravertebral tenderness, which is a huge giveaway that there's nothing to worry about. Deep tender reflexes are 2+. Abdomen is soft. Cervix is long, closed, and posterior. What is the most appropriate next step? So everything we're reading in this question are normal things. The cervix is supposed to be long, closed, and posterior until she's ready to deliver. There should not be any spinal or paravertebral tenderness when you click on all those paravertebral areas. None of that should hurt. That's indicative of actual things that might require an MRI later on. Whatever happened in her pregnancy before was already done. Like, it doesn't matter anymore. The only thing here that's a little out of whack is the 44 pounds. As we saw earlier, the average weight gain in a pregnant woman is 25 pounds. So she's almost approaching double that weight gain, majority of which might be because she herself is not the baby, is she herself might have been eating a lot more. I don't think she's pregnant with twins or anything, so she might just not have taken good care of herself, right? So low back pain is common in pregnancy, especially in the third trimester. Contributing factors include exaggerated lordosis and altered posture due to the enlarging uterus, weakening of the abdominal muscles, and increased joint and ligamentous laxity. Risk factors include multiparity, which for her is a multiparity. Multiparity would be having twins. This is not a multiparity for her, but this isn't her first pregnancy, is what I meant to say. Back pain with prior pregnancy and excessive weight gain, which is probably her issue, right? A history of neuroaxial anesthesia does not increase the risk of long-term back pain, but they spent a lot of time telling you all that shit to really make you think something pathological might be happening. But it doesn't matter what happened in her last pregnancy in terms of how it was managed. because it's irrelevant right now. Back pain during pregnancy typically manifests as mechanical back pain, which is achy pain that is worse with activity and relieved with rest. However, pregnant patients should be assessed for non-mechanical causes of pain, preterm labor, pyelonephritis, and they did that. Right? They checked her and she didn't have any dysuria. Worrisome features include fever, neurological deficits, and recent epidural anesthesia. Constant non-positional nocturnal pain suggests possible malignancy or epidural abscess, but they checked for that because there was no spinal or paravertebral tenderness. Right? So, in pregnant women, nocturnal position-dependent pain is common and benign. Right? She had position-dependent pain. She didn't have pain that was just happening, and she definitely didn't have fever. She didn't have bowel or bladder incontinence. She had urinary frequency, which is common because the uterus is compressing. So the big uterus, the way it's placed in the let me see if there's a picture for that here. The big uterus is right on top of the bladder. We can see this here, actually. So you see this big uterus? And that's the bladder right there, down there. So clearly it's squeezing the bladder. So if there's even a little bit of pee in the bladder, it has to come out. Right? So pregnant women constantly feel like they need to go urinate. Similarly, the big uterus is also squeezing on the rectum behind. So oftentimes constipation seems like a problem for pregnant women. Right? So these are all pretty common complications, common problems, common difficulties that pregnant women have to go through. And it's all related to the physiologic positioning, wrong chapter, physiologic positioning of the baby. Right? So we can see here as well, right? You have your gravid uterus compressing the bladder, and then this is the rectum behind. So as the baby gets bigger, when the mom is laying on her back, the head here is going to squeeze on the rectum, not allowing feces to pass. And when the mom is standing, the heavy baby is going to squeeze down on the bladder, making her need to pee over and over. Right, so these are all completely normal things that occur. So her urinary frequency was normal. Urinary frequency was normal, and nocturia also. But there's no hematuria, there's no dysuria, so it's not an infection. It's not a UTI. Patients with no concerning findings, such as her, should be given reassurance that the back pain is normal and will resolve after she delivers. Conservative management would include behavioral modifications like supportive shoes and a firm mattress, and of course exercise. But not right now, not at the 32-week gestation. This had to be done earlier, in her first trimester. Acetaminophen is safe during pregnancy, although its effectiveness in low back pain is limited. However, NSAID drugs are avoided in the first and third trimesters. Opioids are also avoided in pregnancy because respiratory depression is a problem, and opioids would affect the baby, which can really cause the baby to be addicted. Right? This is a common question. A mom that was using opioids during her pregnancy because she didn't want to have any pain whatsoever, then the baby is born with flu-like symptoms and constant crying because the baby is feeling pain that isn't really there. The baby has opioid withdrawal. Right? So the flu-like symptoms are usually a little bit of a throw-off, but that's exactly what happens in a baby that's born with opioid withdrawal. All right. Here they tell you some more things that we read in the question already, but that's generally all you have to worry about. Now here, next thing we're going to be seeing thrombocytopenia in pregnancy. All right, so what's happening? 30-year-old woman, G1P0 at 29 weeks gestation, comes to the office for a routine prenatal visit. She reports increasing fatigue, shortness of breath with exertion, and bilateral leg swelling over the past few weeks. She has had no vaginal bleeding, contractions, or leakage of fluid. So no red flag symptoms. That's what that means. Always look for that. So when you're working with a pregnant woman, these are the things you care about. Have you had any vaginal bleeding? No, because there shouldn't be, right? There shouldn't be any menstruation, and no other reason to be bleeding other than menstruation in women for the most part. Contractions shouldn't be occurring because then the baby's ready to come out. And leakage of fluid shouldn't occur because then that means you might have a rupture of membranes, which would again mean the baby's ready to come out. So she hasn't had any of those red flag issues. Fetal movement is normal. Her initial prenatal visit is at 10 weeks gestation, and results of CBC at that time were pretty good. Okay. Today, blood pressure, pulse, respiratory rate is normal. Cardiac exam is normal. Lungs are clear. Fundal height is 29 centimeters. And fundal heart rate is 160. Okay, these are all normal. Bilateral lower extremities have 2+ pitting edema up to the knees. Results of a CBC today are showing a far lower. So if I undo where we underlined, this is looking like what the question is about. and almost halved, right? More than halved. So platelets are looking a lot lower. Third trimester HIV and syphilis tests are negative. What is the most appropriate management for her? Well, nothing really, right? There's no reason to do anything. Why would you do anything? She doesn't have any weird symptoms. Never do something for a patient that isn't here to complain about some kind of symptom, or if the patient doesn't have a reflex symptom that you are concerned with. I don't see anything to be concerned with, and nor is the patient herself concerned with anything. So that's one of the many ways to evaluate whether or not you should pick the answer choice reassurance. 25% of people chose 24-hour urine protein collection. This is something you do for hypertension in pregnancy. This is often going to be the correct answer choice, because one momentary collection of urine is not enough for a pregnant woman, because pregnant women don't accumulate urine in their bladder and then urinate it all out. They keep urinating. So every time a little bit of urine comes in, they go urinate. So then you're not really going to get much. So you collect all the urine in 24 hours and then evaluate that. But that's not what she needs. This patient most likely has gestational thrombocytopenia, a benign condition that causes an isolated mild thrombocytopenia. Gestational thrombocytopenia occurs in 5 to 10% of pregnancies and is likely due to physiologic increases in plasma volume during pregnancy. So it is basically a dilutional effect. It is commonly diagnosed in the 3rd trimester on a routine CBC, as in her, but can arise as early as the 1st trimester. Patients are asymptomatic, so she doesn't have bruising, bleeding, or any anemia, things that could occur with thrombocytopenia. Patients are asymptomatic or have normal physiologic symptoms in pregnancy, such as her fatigue and edema. A 24-hour urine collection for total protein is used to evaluate preeclampsia, which can cause thrombocytopenia, but these patients usually have a platelet count way under 100, and they would have hypertension, which we don't see. Right? Patient doesn't have hypertension, so then we don't need to worry about that. This is supposed to be 100K, not L, right? So way under 100K, which was not the case here, right? Her platelets are low, but not low enough for her to have any thrombocytopenia symptoms. Right, here's a list of all the things that would cause thrombocytopenia in pregnancy. Right now, this patient just has the first one, gestational thrombocytopenia. So we just saw a question on the first topic. This one is this question. Then you're going to get questions on all these other things as well. Right, you're going to get questions about preeclampsia with severe features, or HELP syndrome, which has the hemolysis and all the other things that HELLP stand for. Immune-mediated thrombocytopenia, very common question. Very, very, very common thing. TTP and DIC, right? All of which are things from the hematology chapter of step 1. We looked at all this already. Worth revising if you forgot the key features of ITP and TTP. But generally speaking, these questions, as you can tell compared to the one we have right here, will have significantly more symptoms, right? You can see there's going to be some mucosal bleeding, some neurologic symptoms, which was one of the key features of TTP. Right, remember the fun art mnemonic I had? So anemia, renal, thrombocytopenia, neurologic symptoms, and fever. Right. So those were the things that the FN art stood for this thing, and then just ART was the thing for the other guy. But again, these are just some things you would go back and revise if you forgot about them. We're going to see questions about them as we go further in, but not here. Right now, we're just looking at things that are normal, such as the gestational thrombocytopenia in pregnancy. It occurs, it's not a problem, nothing to worry about. Right. Here's another question. This one is about the liver now. Intrahepatic cholestasis of pregnancy. 29-year-old woman, G1P0, 30 weeks gestation, comes to the office for a routine prenatal visit. For the past week, she has had increasing pruritus that has been most severe on her palms. So we know, we've seen this over and over. Most questions about the liver, where something was wrong with the bile, often led to bile going into the skin, into the blood, right? Not the skin, but into the blood flow. And then as it goes throughout your blood, you noted patients who had pruritus. In these patients, the pruritus was even worse after a hot shower, right? We saw all of these things when we did GIT. She has tried using oatmeal baths and lotion, but continues to have itchiness. She also has nausea and difficulty sleeping due to pruritus and increasing back pain. So far, the song in this question is just a music of pruritus. That's all she has. No other really concerning features, right? Nothing really bad. She has chronic hypertension that has been well controlled during this pregnancy. Wonderful. Blood pressure is 138/86, which actually doesn't look very well controlled, but if they're saying it has been, then it has been. Fundal height is 30. Fundal heart rate is 150. There are multiple excoriations on the abdomen and thighs. So she's itchy in the abdomen, at the abdominal area and the thigh area. That's really like weird, right? We don't really get that kind of itchiness on the abdominal and thigh areas that much. The remainder of exam is normal. Lab results are given. LFTs, so total protein 4.5. Alk phos is normal. Liver enzymes are a little elevated. Remember that they're supposed to be in the 30s. Right? They're supposed to be in the 30s. They're slightly elevated. Total bile 26, which is also bad. That's too much bile. Normal is supposed to be less than 10. So what is the best next step in her management? Give her ursodeoxycholic acid. Or earlier we saw ursodiol in step 1. Very high yield medication. Very easy thing to use, deals with the problem super simply. So what's happening? Her pruritus, which is the only issue she came in with, that is most severe on the palms with no associated rash, is consistent with intrahepatic cholestasis of pregnancy, which typically occurs during the 3rd trimester, likely due to estrogen and progesterone levels that cause hepatobiliary tract stasis and decreased bile excretion. Back in GIT step 1, we saw the effects of progesterone in slowing down bile movement, right? These were some key things we saw back in step 1. The various things that progesterone is related to is actually, I'm not sure what page, actually I haven't revisited that page enough, but it is actually listed somewhere in the book. Let me see, ovulation, menstrual cycle, all the things that progesterone does. Where did ACG, HPL. Where do they talk about it? Androgens. Here we go. So we got DHT to testosterone, and then the next one. Where's the other guys? This is why? This is just the testosterone stuff, not the estrogen and all that. Well, it's somewhere, but if you find it, you'll see it somewhere in the book where they talk about all the things that progesterone does. They list out all the things, and in my book, I actually listed out anything else they were missing as well from different parts of the book, because in GIT we discussed it. In GIT, when we were looking at, and again, I wouldn't know where in GIT right now at the back of my mind, but somewhere in GIT we discussed that one of the key things that progesterone was doing in the GIT section was affecting, oh, here we are, was affecting the key process of, they have it listed here, body temperature, endometrial, thick cervical mucus, endometrial, blah, blah, blah. No, they didn't list out the key thing right there. But here we go. So this one is about the gallstones, estrogen-induced cholesterol hypersecretion, and progesterone-induced gallbladder hypermotility. So I listed out one extra thing that these guys do, right? And this page they're talking about estrogen and progesterone. These guys play a lot of roles in many different things, not just sexual things, not just the development of a baby and the sexual characteristics. Also right here we can see the other pathogenesis in the second question was increased secretion of cholesterol. Why does she have increased secretion of cholesterol? Because higher progesterone levels cause smooth relaxation, decreased and incomplete emptying of the gallbladder, and subsequent bile stasis, right? So progesterone is the key guy that's causing the symptoms in our question right here as well. Right? So estrogen and progesterone both play a role, but progesterone is the one that causes the bile stasis that they're talking about in this question. Estrogen was the one that caused the cholesterol hypersecretion, right? So together, the two things are going to be problematic, and that's what we're seeing in her. Of course, those two things, the estrogen and progesterone, are heavily altered during pregnancy. So they play a role in all different parts of the body, all your different organs. Here we're looking at what's happening in the liver. This results in elevated total bile, which are diagnostic of intrahepatic cholestasis of pregnancy, and cause development of a generalized intractable pruritus that is worse on the palms and soles. Some patients may have right upper quadrant pain and elevated aminotransferases. Alk phos is often elevated, but is not specific for ICP because it is also produced by the placenta. ICP does not increase the risk of maternal complications. However, due to transplacental passage of bile acids, it does increase the risk of fetal complications like fetal demise, meconium-stained amniotic fluid, Thus, management should include both treatment of maternal pruritus and prevention of fetal complications. First-line treatment is with ursodeoxycholic acid, which improves pruritus and may improve obstetric complications. In addition, patients require regular fetal assessment and delivery at 37 weeks, particularly if the total bile acids are more than 40. Right now it's 26. So that's all you're really seeing here. So delivery at 37 weeks gestation is one of the answer choices you may have to pick. Right? Don't let the baby stay pregnant in there for too long, because the elevated bile can cause, as they said here, fetal complications. Could kill the baby. So you don't want that. All right, so that's the thing with the liver. Here, now we're looking at cystitis, so bladder things, cystitis and asymptomatic bacteriuria in pregnancy. 29-year-old prima gravida at 12 weeks gestation comes to the office for a prenatal visit. So this is her first time being pregnant and she's 12 weeks pregnant. She feels some pelvic pressure but has no vaginal bleeding or discharge. She completed a course of antibiotics at 10 weeks gestation after a urine culture grew 100K colony-forming units of E. coli. That's pretty problematic. She has had some urinary frequency but no dysuria, urgency, or hematuria. She has no chronic medical conditions and has had no surgeries. All right. Temperature, blood pressure. So blood pressure is looking a little extra low. Pulse, fetal heart rate. Okay. Uterus is non-tender, palpable just above the pubic symphysis. What is the best next step in her management? Repeat urine culture. And that was the correct answer choice. 67% of people picked it. 22% of people chose routine prenatal care only because they wanted to go with the, oh, everything's okay now, we don't need to do anything anymore. But she has had some urinary frequency. Now, at 12 weeks gestation, urinary frequency doesn't make that much sense. See, we just said that the big baby will be pressing down on the bladder when the woman stands up, but it's not that big at 12 weeks. It's big, but not that big. She's still in the first trimester, basically. Urinary symptoms are common in pregnancy due to bladder compression by the enlarging uterus. Cystitis and normal urinary symptoms are distinguished by screening urine culture at the initial prenatal visit for UTIs. Pregnant women have increased risk of acute pyelonephritis due to progesterone-related smooth muscle relaxation. So you can see how I've read and bolded all the key pathophysiology things for each of these questions, especially when they're related to progesterone or something, because that's a big thing you have to know about pathophysiologically. So that progesterone-related smooth muscle relaxation causes ureteral dilation, allowing bacteria to ascend readily to the upper urinary tract. So treat patients with really high colony-forming units on urine culture, even in the absence of symptoms. Treatment is with oral antibiotics as depicted on the table to the left. Right? So she completed a course of antibiotics already, but today you need to check her urine culture again to make sure it is actually all fixed, even though she doesn't have any symptoms. Because the urinary frequency here could be due to an infection that's still there, right? Otherwise, she has no reason to be having urinary frequency at 12 weeks gestation. The baby isn't that big, right? So here we can see some of these asymptomatic bacteriuria symptoms and management. Right? Nitrofurantoin, amoxicillin, fosfomycin as a single dose, the most preferred one. That's the most preferred answer choice. Single dose of fosfomycin. No fluoroquinolones in all trimesters, and no TMP-SMX in the first and third trimesters. But we generally think of no TMX at all. Like, just don't do it. Right? So these guys are teratogenic in a sense because they can cause symptoms that are pretty bad for the baby and the mom. Right? Here we see another pyelonephritis in pregnancy. 19-year-old prima gravida comes to the emergency department for evaluation of right-sided abdominal pain and fever for the past 2 days. Pain has progressed over the last few hours and is now unbearable. Right? So abdominal pain and fever, this is bad. This we definitely need to do something. She has had increasing fatigue, nausea, and anorexia, but no vomiting or diarrhea. She has had some non-painful contractions, but no vaginal bleeding or discharge. She has had no prenatal care and is at 24 weeks gestation by date of her last sure regular period. She has no chronic medical conditions and has had no prior surgeries, doesn't smoke, drink, or use drugs. Vitals are still showing her high fever. Tenderness over the right flank, but no abdominal rebound or guarding. So tenderness over the right flank, that's, the flanks are where you have your kidney and the ureters. So for her right flank, this could be related to her right kidney or right ureter. Uterus is non-tender, cervix is closed, amniotic memories are fine. Fetal heart tracing is shown below without markings. What is the most likely diagnosis? So now, the fetal heart tracing that are given here may not mean much to you because you may not have studied it yet. But the fetal heart rate, you can see the fetal heart rate up and down, it's too fast. Right? It's way too fast. It's not supposed to be that fast. So this is just fetal tachycardia. Right? Fetal heart rate is supposed to be pretty high, but not this high. Right? So now you need to start figuring out what could be wrong with the baby, what's bothering the baby. The baby must be bothered by the mom having a fever. This is acute pyelonephritis. Pregnant women are at increased risk for acute pyelonephritis due to increased urinary stasis, mild immunosuppression, and the same progesterone-related ureteral dilation as the previous question. Like most patients, pregnant women with pyelonephritis have nausea, high-grade fever, and flank pain. Maternal fever and tachycardia also lead to fetal tachycardia, where here the heart rate is 180, right? More than 160, as seen in her. On exam, costovertebral angle tenderness is common due to retroperitoneal inflammation, which can also extend to the abdominal pelvic cavity. This can cause obstetric symptoms such as uterine irritability that can progress to preterm labor. Severe pyelonephritis can also cause maternal sepsis, ARDS, and fetal compromise. Due to high risks of severe complications, management is with hospitalization and empiric IV antibiotics like ceftriaxone. Right? 25% of people chose intraamniotic infection, which is a bigger problem. And that would not just cause fetal tachycardia, but it would cause other issues as well. Intraamniotic, this is now an infection inside the amniotic fluid. Intraamniotic infection would present similarly, but this is a diagnosis of exclusion, and her flank abdominal pain makes acute pyelonephritis more likely. Plus, her non-tender uterus, closed cervix, and intact membranes make intraamniotic infection very unlikely. Right? So we're going to see what intraamniotic infection looks like later on. Here we're seeing pregnancy and exercise and the syphilis manifestations. So syphilis manifestations and then some other things. This just keeps going on. There's a bunch more to look at. But we'll stop here for now and we'll continue tomorrow. Tomorrow I want to start with this fetal tachycardia thing. Pay a little visit to what these fetal heart tones look like. And then we'll continue on with the rest of these practice questions to get an understanding of this and revisit prenatal care. All right. So thanks a lot for joining, guys, and I'll see you all tomorrow morning.